right, everybody. Hi, can you hear me? I bet you could hear me even without the microphone, can't you? I'm sure you can, because I got one of those big New York mouths, all right? I just am known everywhere. All right, so we're doing something different here tonight, but firstly, I want to thank everybody for coming here tonight. I'll say good evening and welcome to an MS Views and News program. For those that don't know, MS Views and News is not related with any other MS organization anywhere in the world. We do our own thing. We're providing patient education, we're providing information for the patients, for the caregivers, and for anybody else affected by multiple sclerosis. For those that don't know, my name is Stuart Schlossman, and I do appreciate and thank you all for coming out here today again. Before I continue, though, I want to thank Genzyme for providing us the grant to do today's program. I would like everybody to thank Genzyme for helping us provide this program today. Thank you. In addition to Genzyme, we have other sponsors. We have Accorda Therapeutics, Bayer Healthcare, Biogen IDEC, Novartis, Questcor, Teva, and a few others here and there. And we would like to thank all of them as well. Additionally, we have a lot of volunteers, and we have support group leaders that are not support group leaders for MS Views and News, but for other organizations, and we do appreciate when those group leaders help us to get our message out so that way you all could get down here and learn and be benefited by the programs we're providing. For that, we want to thank today Nada Cuevas and Ian King, and Lourdes Guest. And Lourdes Guest as well, because she helped with this as well. So we do want to thank all of them for coming and for helping out. And of course, I want to thank all of you for getting down here today. This is our 18th program of 2013. We just started doing programs in 2010. We have now done over 70 programs since we began doing this. And why did we begin doing this? Because I too have multiple sclerosis. And when I was first diagnosed, I couldn't find information. I couldn't find an organization that I could go to one of their programs and see and be benefited by it for everything. We don't just do one specific topic. We try to range all of our programs to encompass a tremendous amount of detail, and so we're hoping that you can learn from what's being presented and then come back and be part of the Q&A that we're going to do as well. So, going forward, we have some other programs coming up in this Central Florida area over the next few months. On August 24th and September 10th, we're doing Spanish language programs. For those that speak Spanish, great. Maybe you also understand English, great. But maybe you have family members that don't understand English so well, and they can learn and be benefited by these programs. And those are the people we really want to have come to these programs. So if you have a family member or a friend or somebody whom you want them to understand what's going on with you, that's the program to bring them to. Bring them to these Spanish language programs. We're going to be doing one on August 24th in Lake Mary. We're doing another one at the Holiday Inn across from Universal on September 10th. And we just got approved to do another one, and that will happen somewhere by the end of by the end of October. Sorry about that. So then also on October 3rd, we were just given approval to do a program. We're going to do in English here in Maitland. Okay, and we're going to have Dr. Honeycutt speak at that program. So again, we're just trying to provide as much as we can to as many as we can. And again, we're doing it all over the state of Florida, and hopefully in 2014, we're going to get out and do programs in Atlanta, Birmingham, and Charlotte. Anybody understand what Atlanta, Birmingham, and Charlotte represent? ABC. That's how it all began. Okay, the ABC drugs that were out there. I just thought of that the other night, but it worked out great. So, tonight, we're going to have a program that we've never done before. We're going to have two nurse practitioners speak. Normally, we have a neurologist and a nurse practitioner, or a neurologist and somebody else that handles one of the symptom management, one of the symptoms, like a neuroophthalmologist or a psychologist or a urologist. And again, this is just how we're trying to provide. But I learned now that nurse practitioners are probably better than me asking all these different MDs to be there. We want to hear from them because they have compassion for all of the patients. Yeah. And so tonight's program is to be a very comprehensive program, starting off with MS101 for those that might be newly diagnosed. And newly diagnosed could be anywhere up to 2 years because you're still basically just learning. And so we're going to start with MS101 and get into a little symptom management, and then go forward from there and talk about treatment options, MS relapse, maybe a little MRI, adherence, and compliance. And those are topics that a lot of you don't know about. For those that don't know, this website is very detailed with our calendar of events, as well as what pharmaceutical companies might be doing programs in the state of Florida. And you can come to this, and there are drop-down menus all across the top that you can figure out what you want to do, where you want to learn, what organization you may want to connect to, and see what they have to offer as well. Without further ado, I want to introduce our first guest tonight, a guest speaker, and that would be Patricia Pagnotta. And Patricia, come on down. The price is right.
So I'm talking about MS101 and symptom management. What is MS? That is the question that everybody wants to know. It is a chronic, lifelong disease of your central nervous system. Your central nervous system includes your brain, your spinal cord, and your optic nerves. We know that what occurs is it's a myelin that covers the nerve, and that starts breaking down, which develops scars, and that's why it's called multiple sclerosis, meaning multiple scars. It's characterized by relapses, flare-ups, whatever you call them, a progression of disability that is accumulative of either physical and or cognitive difficulties. So we know that that is what characterizes multiple sclerosis. Again, here you will see, and I can direct over here because I would like them to see this. This is what a normal axon looks like. Here is your axon, the myelin covering it, and so you have the nerve body there, and what happens in this normal axon is you have the nerve conduction that goes across one nerve communicating to another through this tail here. In multiple sclerosis, we know that there's an inflammatory process going on and a degenerative process going on. And what can happen in the top picture here, you see where there's damaged myelin, where there's scars, and it can't quite get through as well as it did normally. That is inflammation. You can get degeneration where actually there is a permanent damage. That tail is cut, and so therefore the nerve can't speak to the next nerve. So that's what we're talking about. In multiple sclerosis, we know that this occurs simultaneously. We used to believe that inflammation occurred and then degeneration occurred after the fact. We know now that this occurs simultaneously. We know in persons at their very first attack, when we do a biopsy, that we can see inflammation where there's damaged nerve cells, and we can also see nerve cells that are totally dead. They're not there anymore. But what you see is that the curve changes. Early in the disease, there's much more inflammation, and later in the disease, typically, the degeneration starts to accumulate more than the inflammation. What causes MS? That is the million-dollar question, and we are still waiting for that researcher to be able to tell us exactly what causes multiple sclerosis. We know that there are genetic links. We know that there are certain viruses, certain infections that put us at more risk. We know that this is an impairment of our autoregulation. But can we say what one thing? No, we know a lot of things that are associated, but we have no one cause for multiple sclerosis. We are getting much, much closer, and we know more, but we don't have this will cause multiple sclerosis. So when we look at that, then what is possibly put you at higher risk? Well, unfortunately, females are still the predominant sex in multiple sclerosis in a 3-to-1. Now for every 1 male, there's 3 females that have multiple sclerosis. We know, though, with men as a whole, again, we're talking about as a whole, men tend to have a more progressive and or more disability than females. The most often associated are Caucasians. And again, if you're not a Caucasian, if you're not a white individual, if you are Asian, Hispanic, if you are of black origin, then we know that potentially you have a higher risk. When we look at genetics, persons who are twins that come from the same egg, there's only a 40% chance that the other twin, if one gets multiple sclerosis, the other will get multiple sclerosis. So that's why we know it's not a direct genetic link. And that drops depending upon whether or not, if you are a dizygotic twin, which means there's 2 eggs, there's only a 3% chance. If you have a relative that has multiple sclerosis, your chance of getting multiple sclerosis is less than 5%. So really, genes are not the big story here. We know that there is an association with vitamin D. There's a lot of evidence supporting that persons with multiple sclerosis have low vitamin D levels, but we have yet to be able to say that vitamin D is the sole cause. So again, it's just another one of these associated risks. We know that smoking is not necessarily a cause of multiple sclerosis, but it is definitely a cause of progression of your disease. And it is definitely a cause of the fact that if you have multiple sclerosis and you smoke, we know studies have shown time and time again, your symptoms will be more difficult for you to deal with. So smoking and MS are not friends. Don't do that. Vaccines. Again, there is no absolute connection with vaccines and multiple sclerosis. So, and depending upon the drug you're on, feel free to be vaccinated. Most, if you are on a drug where you potentially have some alteration in your immune system, depending on that drug, you may not want to get a live virus. But again, talk to your healthcare provider about that. Diagnosing multiple sclerosis, as wonderful as technology has gotten, as progressed as we have, is still not an easy process. It is not as easy as one would think. There is not one single test that we can say, you have multiple sclerosis. And still, many of us in the neurology feel like it is still a diagnosis of clinical significance. In other words, we have all these different tests that we can do, but if your history and your exam don't fit, then it doesn't match, and you may not, most likely, don't have multiple sclerosis. We look very carefully at what your history is, what you give to us, and then we match tests to go along with that. So again, those tests help us with building the case for or against multiple sclerosis. And we take great care to doing this because this is a very complex disease and it has significant implications. So we don't diagnose persons lightheartedly with multiple sclerosis. Again, when looking at history, we look for the common things of multiple sclerosis. So we look for those common symptoms. Visual disturbances, which can be eye pain, can be blurring of your vision, can be graying of your vision, can be double vision. We look for things like numbness and tingling, weakness. We look for things like impaired gait problems, fatigue, and difficulty with bowel or bladder. We look for these symptoms, but we also look for them in patterns. So we'll talk about that a bit. Again, we look for them in patterns of relapses. Relapses are new or recurrent symptoms that last for 24 hours. So we're looking for those symptoms, and we're looking for them in ways that fit this pattern. Connie's going to talk a little more about this, so I don't want to belabor this topic here. Again, diagnostic testing for multiple sclerosis. Again, not one test, but the examination is very key and probably the most important. Then now we have MRIs, and MRIs have come a long way and helped us tremendously. So we have MRIs of the brain. We look again at the whole central nervous system. So we look at the cervical spine, the thoracic spine, and oftentimes that will be enough to be very clear that a person has multiple sclerosis. But still, we need to go further and exclude other things that may cause abnormalities on an exam or MRI features that may look like a demyelinating disease. So that's why we do all these other things. Lab tests to look for viruses, infections, B12 deficiencies, vitamin D levels, other things, other inflammatory or autoimmune processes that can cause white matter changes in the brain. We used to do a lot of evoked potentials. We still do that in some situations. And we still do lumbar punctures. I know I have told persons again and again that that is not a necessity to diagnose multiple sclerosis. But the important thing is that we get an accurate diagnosis. And then if we are ever in question, then we will go to the nth degree to make sure that we are clear that a person has multiple sclerosis before we give them that diagnosis. And that may include a lumbar puncture. And again, blood tests can rule out other things like metabolic abnormalities or cancers. How is MS monitored? It's very important. This is if you take away anything about MS101, once you've been diagnosed, you need to know, how do I know how well I'm doing? Well, how do you know how well you're doing? These are the things that we look for standardly. Have you had a relapse? Are you changing in disability? That again includes both physical and cognitive disability. We look at MRI activity. It is not the sole test that helps us, but it does help us very significantly monitor a person's multiple sclerosis. So these are the three things that are important as objective tests for us, or objective examination findings for us to determine whether or not your multiple sclerosis is doing well. MRIs. I just want to spend a very brief moment here talking about MRIs. This is not a lecture on MRIs, but I want to give you the feel for what does that mean. We look for gadolinium enhancing lesions. Gadolinium enhancing lesions are lesions that will light up after you're given that contrast. That means this is a new lesion. It's been there for 30 days or less, and it signals activity that is going on at the cellular level where there is active demyelination or inflammation occurring. So when we're doing MRIs, we're looking for these gadolinium enhancing lesions. We look for these on relapse MRIs that we do and on regular annual MRIs, or however often your provider is doing them. Flare images. Flare images are T2 bright spots. What we're looking for are the clouds. When you look at your MRI with your provider and you look and see all these nice fluffy clouds. We live here in Orlando. Lots of fluffy clouds in Orlando. That's nice and beautiful in our sky. You don't want a lot of fluffy clouds in your brain. So we are looking for those fluffy clouds. We would like to see a sunny day with not very many fluffy clouds. So you can have new flare T2 abnormalities. These would be not new lesions, but new lesions compared to the last time that you had an MRI. Something that shows up on a flare that does not show up on a gadolinium enhanced study means that it has not been less than 30 days. So it may be new when you read your report, new compared to the last time you had an MRI, but not new in that it's not part of maybe your current relapse or since, again, it's since your last MRI. And T1 hypointensities. These are commonly referred to in layman terms as black holes. I tell people, think of Swiss cheese. I used to eat a lot of Swiss cheese. So if you just think of something that has holes, and a piece of cheese with holes, you are missing some cheese when you eat that cheese that has holes, because there's no cheese in those holes. When we're looking at a person's brain and we see black holes, where the cerebral spinal fluid is black in these hypointense areas. So this is where there is no brain anymore. Your cells, those neurons, have shrunk up, died, gone away, and now cerebral spinal fluid lives there. That is not what we want to see happen. So if your MRI is not stable, you could have gadolinium enhancing lesions, you could have new old lesions, which are the fluffy white clouds, or you could have black holes, Swiss cheese in your brain. You don't want those things. Okay, there are forms of multiple sclerosis. The most common form, and what you hear us talking about all the time, is remitting, relapsing multiple sclerosis. And that is, again, the most common. That's where persons have symptoms, they come on, they get better, oftentimes early in the disease because there is a reparative property and plasticity of the brain. Persons will get back to being totally normal, just like before they had their first symptom. And that may go on for years. That could go on for as long as a person has multiple sclerosis. They get these attacks, go away, go back to their baseline, attacks, go away and go back to their baseline. They could start developing some disability over time. And until they continue to develop disability more than they have relapses, we can still consider that remitting, relapsing. Secondary progressive is really when person's disability is starting to accumulate more than relapses. But you can have secondary progressive with or without relapses. The important key is as long as you're having relapses, that's inflammation, and that makes you qualify for drugs that Connie's going to be talking about. There is primary progressive. Primary progressive, thank the Lord, is a very small percentage of persons that we see with multiple sclerosis. And this shows you a picture of going down a slide or going up a slide, depending upon how you're looking at it. What it is, a person that develops a symptom, disability, and that gets worse and worse. So they start mounting disability. Don't have relapses, just continually get worse. Now, some primary progressive patients will do that over decades. Some primary progressive patients will do that over years. We really don't know that, again, until we follow a person for a period of time, how that's going to be. And there are some persons that do go from remitting, relapsing to progressive. So that is possible. There are also progressive forms of multiple sclerosis where you're continually getting worse, but superimposed on top of that, you're having relapses. And so that is primary relapsing multiple sclerosis. Those are the 4 types of multiple sclerosis. So I'm going to build this slide. And so this is a very nice picture. I did get the ability to show this to you. So this is where you see we are most effective. Here, before disability starts, is key where we would like to be treating a person with multiple sclerosis. If we treat persons early, the disability curve is much less. If we start treating them later, studies have shown us that the disability curve never quite catches up to people who were started early. And for persons who never had the ability to have disease-modifying therapies, this is where we know the natural course of multiple sclerosis is. So, yellow is a beautiful color. treat early. We know if we treat early, we are changing the face of multiple sclerosis. So that is the most hope, and the fact that we are continuing to develop drugs. So that is a wonderful thing. So in summary, please keep in mind for this Multiple Sclerosis 101 that MSA is unique to every individual. There are commonalities that I talked about, but that's large group of persons, but every person has their own unique course. There are common features. The other thing is that this, again, is a degenerative disease that is chronic. It does not go away. We do not have a cure at this moment for multiple sclerosis. It's characterized by these relapses and disability. We've again made dramatic strides in helping, and there are also multiple ways that we can manage your symptoms. So the hope is, again, in the fact that we are getting better at controlling the disease and we can manage symptoms, but it does not go away. All right, now we're going to slide on into symptom management. And I'm going to cover these things very quickly. The topics I've been given is cognition, bladder issues, pain, spasticity, visual disturbance, and fatigue. Cognitive impairment in multiple sclerosis, CI-MS. What are the myths? Persons think that this was only present in 3% of persons. That's not true. These are all things that are not true. That only individuals with severe disability had cognitive impairment. That only persons who had progressive forms of multiple sclerosis had cognitive impairment. That it only occurred late in the disease, and that it was not related to MRI activity, and that cognitive decline was mostly related to the severity of depression. Those are all false things. What we do know about cognitive impairment is it can happen at the time of diagnosis or even before we make a diagnosis. It is possible. That cognitive impairment is not correlated with physical function. And as opposed to age-related cognitive impairment in persons with multiple sclerosis happens much earlier, and it can have disabling effects on persons' lives. Again, this is a disease of young people. Yes, old people continue to be diagnosed, and young people do get older. But when you're young and have these problems, it's much more disabling than when you're older. And it is true, again, that multiple sclerosis patients, their symptoms vary, the course of disease varies. Nothing is different about cognitive impairment in multiple sclerosis. It varies from individual to individual. We know that the MRI does tell us an awful lot about whether a person potentially has cognitive impairment. The lesion load, the atrophy that we see in the brain, that we typically look at the third ventricle and the thalamic region, we know that that definitely correlates with cognitive impairment. And that symptoms of apathy and indifference and euphoria are typically more related to cognitive impairment in multiple sclerosis than persons with depression. So what is not affected? Procedural learning, very learned tasks. That typically is not the most common affected. Standardized testing is not most cognitively most affected. Basic attention is not, again, most commonly affected. And your semantic memory, meaning general information, facts, things that you learned along the way, is typically not affected, and neither is your vocabulary. But what is commonly affected? Processing speeds is one of the biggest problems in persons with multiple sclerosis, the ability to put things together and put information and spit it out quickly. Multitasking, again, becomes difficult. Complex attention, executive functions, The ability to decide, should I buy this, should I not buy this? Decision making, that's part of what your executive function helps you do. Your judgment, your ability to maybe be reserved and not just spit out the first thing that comes in your mind. And I said vocabulary was not affected, but person's word finding is. So although I may have a vocabulary of 10 million words, if I have cognitive impairment and multiple sclerosis, I may only be able to, on an average day, retrieve 90% of those words, and some days maybe even less of those words. So it's not that you don't know words and can't understand, but it may be difficult when you're talking. You may find, I was going to say, and you just can't get the word to come out. Episodic memory, the ability to remember recent facts is often impaired. And your working memory, the things that are stored a little bit deeper in your brain, sometimes are difficult to get out. And then putting things from, when I learn it today, how do I keep it for tomorrow, for the next day? So your brain being able to learn a new task and to try to put that back into an area deeper in your brain, encoding it into more long-term, that becomes more difficult. So what do people complain of? So if you're worried, do you have possibly cognitive impairment? Again, possibly, because this is common in other things too sometimes. But the tip of the tongue type phenomena. Again, I'm up here, I don't know what I was going to say, I can't think of that word, it just won't come out. Or, I thought of that word, I said that word, it was a great day, the sun is shining, isn't the sun black? I meant to say the sun was yellow, and I come out and say black. I blank out in familiar areas. I was here before, I don't really remember where I was. Difficulty following directions or conversations. How many people, their children or family members come home and they tell them this long story, and by the time they get to the end of the story, you're still stuck at the beginning of the story and lost everything in between, and like, oh my gracious. And what does that cause? So family members or persons then start recognizing that. Not like Alzheimer's, where they have no clue that they have any cognitive impairment. They think life is great. Multiple sclerosis patients typically start recognizing this, and that causes them to withdraw. When I can't perform as well, or I'm embarrassed because I can't think of that word, I may not want to go out and expose myself to individuals who may not think like me. So again, wonderful that there are support groups, because exercising your brain is important, so go to support groups where people do know you. You may require more assistance if you're having cognitive impairment. So if anybody is having these problems, again, this is something that we did not think of as early stages of in earlier times with multiple sclerosis. Please bring this to your provider's attention. Again, cognitive, some clinical features, preservative areas, difficulty, shifting principles, direction, problems with individuals, again, moving from one object to another and not being able to make that shift. Again, most of the time the immediate memory is not affected. So if I told John to pick up that pencil, if he can do it right then and there, he'll pick up that pencil with no difficulty. But if I tell John, please, in an hour from now, go out and feed my horses, and they need 2 cups each. When I come home, John may have not fed my horses at all, or maybe given them a little bit of food, not very much. So it's the immediate memory is not, but things that are not in the immediate memory. And often persons, so I said to John, please go out and feed my horses 2 cups an hour from now. When I get home and I remind John of that, oh, yes, you did tell me that. Or he looks at a picture, oh, yes, those are my horses. I don't remember their names, but those are my horses, whatever. But so recognizing things versus being able to, oh, don't you remember that conversation or that movie? But when they see the preview, oh, yes, I saw that movie before. So prevalence, I talked to, this is not just 3% of persons with multiple sclerosis. In fact, we know that up to 70% of persons with multiple sclerosis at some time may have some degree of cognitive impairment. Again, some degree, not the typical Alzheimer's patient. It progresses extremely slowly in persons with multiple sclerosis as a rule. So how is it identified? Well, the first thing is recognizing it. So that's why I spent time telling you about all these symptoms. So if you feel like you have these symptoms, this is one of those invisible symptoms. This is something, although we can see it on MRI, it's not something that the every average day person you encounter might experience this. But if you are feeling this, then you need to bring it to our attention. Persons oftentimes are in denial. I don't have any problems with, and they may not want. But again, we know that there is help for this. The other thing is that persons with higher levels of education, persons that are still in the workforce, persons that are using their brain, that the brain atrophy is slower. So again, they may be having some subtle symptoms, but may not recognize them as quickly as someone else. So if that's occurring, again, please don't be bashful. So what can we do to diagnose persons with cognitive impairment? Well, the gold standard is neuropsychological testing. And neuropsychological testing typically is cumbersome in that it's not a quick, go into an MRI, 45 minutes later we know. It takes 3 to 5 hours. What they're doing is testing every area of your brain, all of these different functions, and they're giving us a differential diagnosis. What is associated to multiple sclerosis? What might be associated to other symptoms, other medical problems, drugs you're taking, other things. They also tell us about what a person's ability is for a cognitive, vocational training, or give us hints about a disability. So it's very important for disability measurements if we're thinking of that. So it's extremely important. Anytime I put drugs up on a screen, and I'm not even going to talk about them, they're here for you to look at. Really, these are things that you need to talk to your providers about, but just for you to know that there are medications that we can use to help persons with some of these problems. If part of your issue is fatigue or speed, cognition, we can help stimulate your brain with some of the stimulants that we use that may help you think a little bit more clearly. Other ways go back to some hard work, retraining, building your brain, luminosity, some other areas that we can use to help persons exercise that muscle like any other muscle in their body. And behavioral compensation. If you have difficulty remembering things and you know that, it's good maybe sometimes to take notes, or in this day and age with smartphones and all the other informations we have, it's very easy for persons to use that technology once they learn how to use that technology. So again, in treating cognitive restorative is all about getting the brain back up to speed. We know that the brain is very placid. We can reteach an old dog new tricks. That's the key here. And then compensatory treatment is really looking at helping a person adapt to problems that they have. So those are the two keys. Bladder issues. On to another topic. So there are 3 different types of bladder problems. The inability to store, the inability to empty, or a combination of those 2 things. So what are sometimes symptoms of the inability to store urine? Well, you might have to go to the bathroom frequently. You may feel an urge to go. You may have incontinence. You may have difficulty or you may be voiding at nighttime. Inability to empty gives you the same urgency. Your bladder's always full. You feel like you gotta go. You get to the bathroom, hesitancy. You can't go. You get there, you sit down, or you stand up and nothing comes, and you stand there a few minutes before anything comes. Typically, persons with these problems will find themselves double voiding, meaning they go to the bathroom, empty the best they can, and either massage or try very hard, concentrate to void again to be clear that they've completely emptied their bladder. Again, frequently going to the urine, frequently urinating, or incomplete emptying as measured on testing. And a combination really is a combination of those symptoms. And the best way to determine the difference in these is really to have urologic testing done. And so urologic testing, can some of this be performed in our offices with post-void residuals, bladder scanners? Other more sensitive tests really need to be done in a urologist office. And so if you're having any of those difficulties, a referral to a urologist is definitely something that I advocate for persons. I like to get baselines. I like persons to have that person to connect with and to help us manage. And so they also can help us with persons who have recurrent urinary tract infections, and recognize that outside of just primary bladder problems, urinary tract infections also can cause some of these symptoms. So they help us with that. They help with pelvic floor training, and persons who may have other conditions like benign prostate problems that might cause bladder dysfunction. So the key here is, number one, to maintain a person's renal function. We don't want persons getting infections or renal impairment, that infections that lead to renal impairment, or backup even without an infection that leads to renal impairment. We also want persons to be able to establish a norm of going to the bathroom so that they're not needing to run and miss all the time because they're in the bathroom, or not able to go in the bathroom and sit, and they really aren't going to the bathroom. And first and foremost, beyond the medical issues, is your quality of life. So performing the appropriate tests so that we diagnose the problem and can help you get back out there. Again, there's non-pharmacological ways of treating this. Bladder training, helping persons with behavior modification. I hope that all of you know that caffeine is a bladder stimulant. So if you drink caffeine, you can find yourself needing to go to the bathroom more frequently. And I tell persons, if you sip, you will drip. So if you're sipping all day long, you will be dripping all day long. So I really encourage persons to drink a lot, but to drink here, take a break, drink here, take a break, drink here, so that you're not sipping all day long and then therefore dripping. And again, outside of caffeine, other dietary modifications to keep from making this more difficult. Again, there's pharmacological treatment depending upon what type of bladder problem you have, and they are coming out more and more every, I feel like every month I see a new commercial for some type of bladder problem. So, you know, for you to know that bladder problems are as much a problem in the general population as they are in multiple sclerosis, of general population of persons with chronic disease states. So not general population of people healthy, but people like with diabetes and strokes and other degenerative diseases. There's treatments that we've advanced with spastic bladders, Botox and things. So again, those are services that really need to be provided by a urologist or under their care. So that's a good reason why to take that time to have that assessment done. And again, that allows us to prevent secondary symptoms, which include things like urinary tract infections and reflux going back up into your kidneys. We talked about, again, why to treat. The number one reason I want to treat persons beyond medical reasons is to prevent social isolation. I also want people's symptoms to be well. And if I find a person is not taking care of their bladder issue, they may be up all night, and so therefore they're fatigued, and it can become a very vicious cycle. If you are not very ambulatory, and even if you are ambulatory, if you're wet all the time or whatnot. You can have problems with your skin. So these are very important reasons why we should treat your bladder impairment, beyond the fact that somebody's doing the laundry, and that is not pleasant. Spasticity. Okay, spasticity basically is muscle stiffness. This is a very common symptom in multiple sclerosis. It can range from very mild symptoms of tightness to very severe pain, uncontrollable, a spasm that can happen in any one of your extremities, but most commonly occurs in your legs. Is aggravated by sudden movements or changing in position or temperatures, humidity, infections, fatigue, and tight-fitting clothing. So all of those things can aggravate your spasticity. There are two types of spasticity that we talk about most commonly, flexor spasticity and extensor spasticity. The flexor spasticity typically involves your hamstrings, which are the muscles in the back of your upper leg, and your hip flexors, which are up in your groin. And then if you have problems with your hip flexors, your knees are bent and difficult to straighten them. Extensor spasticity often occurs in your quadriceps, so that's the top of your leg in the front and in the upper legs, and can also occur in your hips and knees. And this causes a person's legs to kind of remain close together, crossed at the ankles. And this can be a common problem in persons with sexual dysfunction. So treating spasticity, the reason we treat spasticity, we'll cover in a minute, but it's, again, another symptom that requires a complex look at things, and not just one thing fits all. First, importantly, before we decide putting a person on drugs, exercise, making sure persons are really stretching those muscles, making sure that they are limber before they start doing activities, varying your activities. So trying to do a variety of different things so that your muscles don't get used to only doing, and you're only using some of your muscles, and that you're using all of your muscles. Again, those aggravating factors, you want to eliminate most of those as much as possible. And this is one of the very key reasons to send persons for physical therapy and occupational therapy, if for nothing else, for an assessment and to get you on a home plan, and then to reevaluate that on a regular basis. Because again, drugs help, and drugs with combination of physical therapy and occupational therapy if you need them. So treating spasticity as far as drugs, baclofen, tizanidine, dantrolene, Botox, which is botulinum toxin, and there are surgical options that we can use. So if you have spasticity problems, in addition to the other things, we can do medications. Pain I brought right after spasticity, because spasticity oftentimes causes pain, so they are often thought of together. But in addition to spasticity type of pain, there's many other types of pain. Persons can report pain as much as 70% of persons at some point will describe having pain, and up to 50% of those persons then describe pain as being chronic. There are no common contributing factors related to multiple sclerosis as far as pain. Age does not put persons more at risk to multiple sclerosis, either age of the individual or age at the onset, your level of disability, or your length of time with multiple sclerosis. So again, it's very varied. It can happen at any point. Women typically report 2 times more pain than men. Again, 2 types of pain. There is acute pain and there's chronic pain. Acute pain is that lasts typically anywhere a month to 3 months maximum, and this can be related to things like trigeminal neuralgia or the Mris phenomena. When you bend your head or flex your head, you get that electrical shock that goes down your spine. and can be banding pain. So these are the most common type of pains that occur with relapses. The chronic pain is when that relapse hasn't recovered and you start with burning, tingling, prickling, the spasticity, musculoskeletal pains from not walking right or using different muscle groups, and headache. We know that headaches are the most common reason for persons to go to healthcare providers, but it's also a common symptom in multiple sclerosis. More persons with multiple sclerosis than people without have headaches. So again, treating pain, there are a list of drugs up here that we treat pain for, and you could shoot the camera up there. This is my list. It's not inclusive. Please, if you have pain, there are many options that we have to treat pain. Please bring that to your provider's attention and discuss that with them. Visual disturbances in multiple sclerosis are very common, and some of those include optic neuritis, decreased visual acuity, double vision, blurring of vision, or involuntary movements of your eyes. This optic neuritis is an inflammation of your optic nerve. This usually is unilateral, meaning in one eye, but it can occur in both eyes. More often, it's a vision that occurs over hours to days to slowly progress, and there's usually pain involved with this and pupillary defects that we see on exam. Optic neuritis management, we know that in the optic neuritis treatment trial, although there was no difference in persons that were treated or not treated in their long-term recovery, we know that there is a difference in the short-term recovery. And so I don't know about any of you, but if I couldn't see, I'd like to be able to see as fast as possible. So even if I knew, well, it might not make me better 6 months from now, if it makes me better next week, that would be great. And so we do use steroids. Athgar is one of the other drugs that we can use that is not a steroid. And then gradually persons will get better, typically in 2 to 4 weeks. And again, like any other relapse type symptom, you may not get 100% better. What's important, annual eye exams. Please have your eye exams done. Follow up with your neurologist or neurology nurse practitioner regularly. Discuss vision problems. As with all, stay on your disease-modifying therapy and treatment as needed and visual aids as needed. So fatigue. Fatigue is a subjective lack of physical and or mental energy as perceived by the individual or the care provider that interferes with usual or desired activities. So it's not what I think, it's what you think and what your significant others think. Characteristics of MS fatigue, it's rapid onset. It occurs and impairs a person's social function. It can interfere with your executive functions. It is worsened by heat, and it can persist over time. MS fatigue statistics, typically it can be the very first symptom that persons complain of, and can occur as many as 2 years prior to multiple sclerosis. And at some point in a person's life with multiple sclerosis, anywhere from 70 to 90% of persons will experience some type of fatigue. 66% of persons say that they experience fatigue on a daily basis. 50 to 60% of persons describe this as being their worst symptom. And 90% of persons report, again, that heat impairs their ability to not be fatigued. And it is cited as the #1 reason for persons to leave the workforce. And it's not necessarily, again, characteristic of any one stage of multiple sclerosis and does not correlate with disease factors. It's a very complex feature. Again, there's MS fatigue, and there are a lot of other things. There's physical health, there's psychological health, environment, sleep disorders, and there is normal fatigue that occurs in persons who do not have any medical problems. So consider that. Again, the causes of MS fatigue, we know that it's part of the immune and neurodegeneration that causes this, and it's typically a short-circuiting when the neurons can't talk to the other, and that occurs most frequently involving the thalamus, basal ganglia, and the frontal cortex, and is, again, more consistent with disability than the type of multiple sclerosis. So whether you have remitting relapsing or primary progressive, your level of disability more correlates with fatigue. Primary MS fatigue is described as lassitude, this overwhelming feeling that comes on and you're tired and you can't think of any other reason that caused that. Secondary fatigue is the short-circuiting, the deconditioning, the pain. And there's chronic and acute fatigue. So acute fatigue is oftentimes fatigue that may be associated with a relapse, may not be. It may be other environmental factors that are going on, and could not be any of that. It just is something that lasts for just the last 6 weeks. When it becomes chronic is when it happens more than 50% of the days for more than 6 weeks. Comorbid conditions for fatigue include things that are put you at higher risk for fatigue: infections, anemia, hypo or hyperthyroidism, cardiovascular disease, pulmonary disease. So these are other problems other than multiple sclerosis. Things that we are what we call iatrogenic causes, which are things that just occur as part of the disease. Treatment causes can be using certain disease-modifying therapies in the first 6 months are more likely to cause fatigue. Other medications that you're taking are commonly associated with fatigue. Every medicine we give most of the time can be associated with fatigue. And diabetic agents also. Sleep disorders, if you do not sleep well, you're probably going to be fatigued. So if you have the bowel bladder problems, if you have restless legs, spasticity, sleep apnea, those things are going to cause you to be fatigued. If you're stressed, psychological health, if you're stressed, having coping difficulties, anxiety, depression, that will enhance fatigue. Environmental factors include things like heat, consuming hot beverages. Studies do suggest that persons of lower educational levels have higher fatigue, and that kind of surprised me, but it's out there. Studies also are divided on ages association. So there are some that say, yes, the older you are, the more associated fatigue you may have, and other studies that dispute that. But fatigue does impair a person's socialization, and coping with fatigue is definitely in part of how a person copes with everything, and social characteristics and cultural characteristics may impact fatigue, how you cope with fatigue. So non-pharmacological management: stop smoking. We know it makes your symptoms worse. Eat healthy, get adequate sleep. Treat your symptoms, plan ahead, energy conservation, and taking naps. Drinking cool liquids, staying cool, personal fitness programs, don't get deconditioned, relaxation, exercise, and accepting help. Sometimes that's very hard. Just allow somebody to help you out. Again, there are many drugs that we can use for fatigue. The key is that there is no FDA-approved drug for fatigue in multiple sclerosis. So just as a buzzword for you to know, if you've ever had problems with getting a drug that has been helpful in MS, please tell your healthcare provider to ask your insurance company, well, what's the FDA-approved drug for that? There's not. In treating person's symptoms, communication is the key. I cannot emphasize enough. I can't look at an individual, and I don't know of many other healthcare providers that can look at an individual and know every symptom you're having. Yes, the exam tells us about many symptoms that you're having, but doesn't tell us about everything. So communicating with us, bringing loved ones to the appointments to help communicate if you can't, keeping a diary, and being open to allowing us to do more than giving you a drug. There are drugs that are good, but drugs do not fix everything. So being open to allowing us to holistically treat your disease. That's it? I believe that's it.